Hi everybody, my name is Meaghan Kenney and I am one of the clinical case managers with O'Connor Professional Group, and I will be discussing obsessive-compulsive disorder with you today briefly as I talk about what this disorder actually is. I think oftentimes we hear the term OCD used in social or casual settings, but we're not actually getting a full understanding of what the full diagnosis actually entails. When someone has obsessive-compulsive disorder, they can have one or possibly two of the primary components of the actual disorder. And if you'd like to look up the disorder further and do a little bit more research on all of the different components, feel free to check out the Diagnostic and Statistical Manual, the 5th edition, to look for more information. First, the individual typically has what we consider to be obsessions, and that usually takes the form of thoughts, intrusive thoughts, recurrent thoughts, persistent thoughts. They're thoughts that the person kind of can't stop, can't control, and they cause a great deal of distress in the person's life. Now, this second piece isn't mandatory in order to make the diagnosis, but it often does coincide because when someone has such intrusive and distressing thoughts, typically they are desperate to find some relief. And oftentimes that comes in the form of some sort of obsessive behavior or some way in which the person can ignore those thoughts. And so sometimes we see this extra piece of a behavior actually taking shape in response to the thoughts in order to alleviate the anxiety. For example, if an individual has a fear that germs are going to harm them seriously in some way, and that's actually causing them a great deal of distress, and they worry about it frequently, and it consumes a lot of time throughout their day, and they worry about it a lot, they may engage in a behavior like repetitive hand washing, and that may feel like they are relieving the stress of thinking that they have germs on their hands that are going to hurt them. Sometimes the individual has what we call insight, so a level of understanding that maybe the thoughts aren't entirely true, but that they kind of can't control them anyway, and that it's still causing them a great deal of distress. And then sometimes people aren't aware that their thoughts might not be based in reality, or it might not have any evidence to support it, and they'll still engage in some of these compulsive behaviors in order to sort of manage their own anxiety. Now, like I said, you don't need to have both of these components in order to have the diagnosis. It's one and or the other, but like I said, oftentimes we see both. The other piece is that the thoughts and or behaviors must cause the person a great deal of distress and impair their overall functioning, and also causes them to use a great deal of time throughout their day to focus on the thoughts and the behaviors. According to the DSM-5, it's at least an hour a day of either engaging in the behavior or being consumed by the thoughts. Additionally, we have to make sure that substance use isn't present and not causing or responsible for maybe some of the symptoms or behaviors that we might be seeing that look like OCD. And then we also have to be sure that another medical or psychological condition is not responsible for explaining these symptoms better than what OCD may explain. And that's OCD from a psychological perspective. That stands for obsessive-compulsive disorder.